can't have any more money. You've already got enough. So our challenge, I think, is to reach those aspirations and to recognize we're not going to get any more money. So how can we think even about that kind of transformation given that kind of constraint? Well, I think actually that there are ways, both from a global societal perspective, but also from the perspective of the individual organization, whether it's a hospital, a group practice, an ambulatory surgery center, that work today, given all of the craziness in our payment systems and health policies. So let me talk a little bit about both of those challenges. We need to do three things in order to meet this challenge. We need to eliminate the overuse of health services, the use of health services when risk exceeds benefit. Patients don't benefit. All they get is the harm of those services. We need to eliminate the waste that is inherent in needlessly complicated processes that exist in almost every care delivery process, in every care delivery site, at least the hundreds that I've had experience with and the thousands that I've heard about. And we need to get rid of preventable complications. Pursuing each of those strategies will save us money now and will either improve quality or, in the case of getting rid of waste inside processes, will at least not impair it. Now that's from a global perspective and from a societal perspective. Individual organizations will find it very difficult to pursue each of these strategies with great enthusiasm because, as you all know, we have payment problems and disincentives to do this. We have disincentives to integrate across care organizational boundaries that prevent the kinds of partnerships that would make this more effective. All of that is true. And we hope and expect that with health reform and with other efforts, a lot of those disincentives will get ameliorated, if not eliminated. But I am firmly convinced that today, healthcare organizations can make enormous progress without having the problem of really impairing their revenues and getting at odds with their physicians. So let me talk a little bit about that and give you some specific examples. Overuse is a very difficult topic for most stakeholders. But the fact is we have enormous overuse of all kinds of health services in the United States. 24 million Americans getting antibiotics for colds, and this doesn't happen rarely. The best estimate is half the time when an adult goes into a doctor's office with a cold, they'll come out with an antibiotic prescription, and that consumes just antibiotics for colds outside of hospitals consumes 21% of all antibiotics prescribed outside of hospitals. It's not limited to drugs. Tympanostomy tubes, those are little ventilating tubes that are put in eardrums in children, the most common surgical procedure in children. The best estimate, and this is an old estimate, 650,000 a year, it's probably closer to 1 million today. Requires general anesthesia. Major complications are not common, but other complications are common. It's mostly performed when there's fluid behind the eardrum, and the evidence is really quite sparse about its benefit, but everyone agrees you ought to wait at least 90 days before you stick these tubes in because the fluid goes away almost all the time on its own. Well, when you look, a study of hundreds of these procedures showed that half the kids got these with a duration of effusion or fluid of 16 days or less, and 75% didn't even wait half of the 90 days. And you can look at imaging for simple back pain, at induction of labor today in women whose pregnancy is 39 weeks or shorter, knee arthroscopy and simple osteoarthritis. The evidence of overuse is overwhelming. It has been an extraordinarily difficult health policy issue for many stakeholders to engage in, but I think we are starting to see the fact that this ground is starting to shift. I firmly believe that our health reform effort to cover another 30 million plus Americans will fail if we do not tackle this problem effectively, and we're seeing the beginnings of a shift. Rosemary Gibson has a book out called The Treatment Trap that talks about overuse from the patient perspective. We're starting to see much more discussion at the national policy level. The national priorities partnership convened by NQF, the National Quality Forum, to identify important areas for the development of new quality measures, identified overuse as an important problem to develop quality measures in, and we are starting to see the beginnings of what will have to be the critical driving force here, which is physician leadership. Will physician leadership prove effective here? I think it has to. We are starting to see it in the AMA's PCPI, or Physician Consortium for Performance Improvement, but I think you should be paying attention to this issue as we go forward, because it is absolutely critical to solving this problem. So that's the first one, overuse.